Morning, everybody. My name is Dahan. I'm from Leiden University in the Netherlands, and I participated in 2 large trials together with Medasense on the validation as well as on the efficacy of the NOL in outcome of our patients. And I will be discussing mostly the 2nd trial that we recently finished. Shortly, my conflicts. Have a good look. Make a picture. Do whatever you want to do with it. Okay, I will be talking about nociception. We've heard a lot already about nociception, and we believe in our institute that nociception is as important as hypnosis, as muscle relaxation, and we're very fortunate to be able to work with the nociception monitor, the NOL index. Like Professor Sessler told you, the NOL index is made up, it's a multifunctional parameter. It has heart rate variability, the pulse pressure, skin conductance, its variability, and their derivative. So that's really important. It ranges from 0 to 100. In our institute, because I use it in multiple cases, even outside of studies, I used boundaries of 10 and 25. So NOL indices below 10 I consider an overdosing of an opioid, and values over 25 I consider an underdose. So below 10 there's too much suppression of nociception, and over 25 there's just not sufficient suppression of nociception. Here you can see the sensor. It's easily placed on the finger. It takes you a couple of seconds. You start up the device and you can start measuring. And we do that prior to any drug given. And we take our time with it, and it gives you a lot of information. This is the study by Martini et al., one of my postdocs. Currently, at the time, he was a resident. And by the way, I'm the only non-resident co-author on this paper. All others were residents, because the interest in this device is immense in our department. So they all participated in this first validation trial. And what we observed in this validation trial, something that you may already know, that blood pressure and heart rate are just very poor measures of nociception and stress. And Professor Sessler already spoke about that and explained it to you. Well, we compared these measures, and the graph on the left side you just saw. We compared these 2 measures to the NOL. And so let's focus on the right side. I hope you can see this here on the right side. Yeah, the ROC curve, and the ROC curve shows you without any doubt that the NOL is superior in terms of detection of mild, moderate, and severe nociceptive stimuli compared to heart rate and mean arterial pressure. So for us that was really an important one, and it made us design a next study. So we made the next step, and that next study is what we call the NOL Trial. In fact, it is called the influence of NOL-Guided Analgesia on anesthesia outcome. And it is a study in which we had one group of patients that received NOL-Guided Analgesia, and the others received standard clinical care. There were 80 patients in the trial, and the surgeries that we targeted were major abdominal surgery without epidural. And the anesthesia technique that I used in this trial was target-controlled infusion, so this computer-controlled infusion that, to be honest, I used that quite a lot with remifentanil and propofol. In real life, I combined my remifentanil always with sufentanil, but for this trial I did not. That is really important to understand. But because remifentanil has very rapid pharmacokinetics, and at the end of the case, when you shut down your remifentanil perfusor, concentration drops rapidly in plasma, and the patient might be in pain. So to overcome that, all patients received a dose of morphine 45 to 60 minutes prior to the end of surgery, and the dose of morphine was around 0.1 to 0.2 milligrams per kilogram to overcome this gap, because morphine is a slow-acting opioid. It takes some time before it acts. So it is to ensure that all patients had adequate post-operative pain relief. As I said before, we had our boundary set in NOL values. When the NOL was over 25, we increased the TCI system of remifentanil, so we increased it in steps of 0.5 to 1 nanograms per ml. And below 10, we reduced it. We had a cutoff, a lower limit of 1 nanogram per ml of remifentanil. Our endpoints primary endpoint, very simple, the amount of remifentanil that we infused. So it's the remifentanil consumption during anesthesia. A simple outcome. Another primary endpoint was the occurrence of inadequate anesthesia events. And we had several. We had the use of vasoactive medication, and you need to realize I work in an institute where we easily administer vasoactive drugs, such as norepinephrine. We easily administer a norepinephrine, especially to elderly patients, and I even start a norepinephrine prior to the induction of anesthesia. But I used it as an endpoint. I thought it was important. Then we looked at hypotension. We had 2 levels of hypotension that we looked at. Severe, mean arterial pressure below 55, moderate below 60 millimeters of mercury. We looked at tachycardia as defined here. We looked at hypertension as defined here, and tachycardia. But now let's look at the right side. This is an actual recording, a live one. I took the picture during the case. You can see on the top right side the number 32, so the patient had a high level of nociception. Here you see the plethysmograph, and here you can see the actual trend of the NOL index. And you see it goes up and down, but if you look carefully, you can see some areas with increased nociception and in between areas with decreased nociception. If we focus on these two, the white circle and the green circle, you can see that nociception was relatively high. We increased the infusion, maybe a little bit too much. It went to around 0. We reduced it a little bit, and at the end, you can see how it works. And what I like about the system, it's not fluctuating all the way up, down all the time. It allows you to titrate your opioid to effect, and it gives you time to do so. So, with this in mind, I present you 2 examples of our trial. I try to find 2 similar patients, more or less. They differ a little bit in age. Patient A received standard clinical care. Patient B received NOL-Guided Analgesia. Their BMI is more or less the same, and this is, by the way, quite a normal BMI in my country. This is the average BMI. Both received laparoscopic prostatectomy, and both received, of course, TCI, remifentanil propofol. Both also, this is a technique that we apply in laparoscopic procedures and robotic procedures currently. That's deep neuromuscular block with rocuronium. In the end, they received sugammadex, so we had a PTC, post-tetanic count of around 1 to 2, quite stable. And as you can see, the target BIS, you can see it at the bottom, in our institute is around 50 plus or minus 5. And you see how we made our decisions. On the left side, decisions were based, like I normally also do, based on my hemodynamics. On the right side, decisions in terms of remifentanil administration solely based on the NOL index. And this is how we had our monitoring. This is the TOF cuff. We use a TOF cuff device. We don't use the TOF watch, because in these procedures, the arms are close to the body, and it's almost impossible to use the TOF watch. This is a very reliable device for especially deep neuromuscular block. We had the NOL device, the NOL monitor here, but it was hidden for the anesthesiologist. On the right side, of course, it was there. You can see a value of 22, so we're in the right range in this patient. So what were the major outcome values? Well, primary outcome is, of course, remifentanil consumption. These are cases, guys. This is just 2 patients, 2 examples. They're typical, but still. On the left side, remifentanil use was 0.12 micrograms per kilogram per minute. On the right side, the patient that received NOL-guided analgesia, it was around 40% less. We looked at inadequate anesthesia events as defined previously, and you can see there were 28 events on the left side in the patient that received standard clinical care, and just 20. Not really much difference, but still. Pain levels were more or less the same. And that's understandable, of course, because they received the morphine, and even if they still have pain levels following surgery, we titrate them to a comfortable level of around 4. And BIS values, by the way, the target was 50, BIS values were around 45. Still allowed in the trial. Well, these are the 2 groups, just to show you that the 2 groups were comparable. Male, females, more or less similar age, more or less similar, etc., etc. But what is important is to see that these were indeed major abdominal procedures. We did lots of urological procedures, lots of large abdominal colectomies, etc., etc. Now let's go to the results. These are 4 of the measures that we took. We looked at the nociception level, panel A, bispectral index, panel B, heart rate, C, and mean arterial pressure, D. In orange, it's the NOL-guided value. In dark red, it's the standard clinical care. And let me guide you through it. So this is, the first one is at baseline, patient is awake. Then we induce the patient and we look whether or not he has lost consciousness. When he has or she has, we take a measurement. Then we intubate, just following intubation, we have a measurement. This is the average value obtained during anesthesia, and this is when the patient opens his or her eyes. Now, what is quite interesting is if we just focus for a second on the anesthesia part. And you can see that the NOL level in the NOL-guided group was within our limits as expected. These are 95% confidence intervals. While the NOL just measured but not guided, we didn't use it as a guidance, is on the lower level, indicative of somewhat of an overdosing of these patients. And if you look at mean arterial pressure, panel D, you can see again that blood pressure was on average, well, what was it, 95, 96, 97, while the mean arterial pressure on average was much lower in the standard clinical care. Really important observation here. Another one is that indeed, like Professor Sess already said, bispectral index is not a good measure of nociception. It behaved quite dissimilar to what we observed for nociception. Intubation is a nociceptive event, and indeed we did see that the NOL went up in both groups, as you may expect. On the other hand, the bispectral index went the other way around. And another important one, heart rate was non-informative whatsoever. No indication whatsoever from heart rate regarding the level of nociception, both at loss of consciousness, intubation, and during anesthesia. Now this is a complex plot. I do understand it, but still it's an informative one. It's a fire plot of the frequency of specific NOL values were obtained from induction. This is intubation, up until 2 hours into the case. The dark red indicate a high frequency of occurrence, and this on top is the NOL-guided group, and the bottom one is the standard clinical care. And I don't want to go completely through it, but you have to believe me, and you can see it yourself, that the NOL-guided group, the levels were more within the ranges that we wanted. But this, of course, is the average of the 40 patients. And by the way, these are also 15 seconds averages. So these are not instantaneous averages. But it gives me a good indication that in the standard clinical care, we really were overdosing. Look at the values are really at the bottom area. Now, to continue on this, here I plot the number of NOL values that are really low, indicative of overdosing, and the NOL values that are really high, indicative of underdosing. Again, in orange, the NOL-guided group, now in blue, the standard clinical care. And I want you to focus on the tails of these graphs. And you can see that especially, there were certain patients that had frequent events that were outside of the limits, and that occurred both for the overdosing as well as the underdosing. And these, especially the overdosing was, the underdosing was quite a significant difference between the two groups. Now, our primary endpoint, this is why we're here. And on the left side, you can see the average remifentanil consumption in the NOL-guided group in blue, and in red in the standard clinical care. And you can see a 33% difference between the two. So we used 33% less opioids in the NOL-guided group. Very important. And you can see over time how this develops. Initially, the opioid consumption is more or less the same, but after about 30 minutes, 45 minutes, they start to separate with a greater opioid use in the standard clinical care compared to the NOL-Guided Analgesia group. But you might say, okay, you used less opioids, so you might have more hemodynamic consequences. Well, to the contrary. An important slide, and maybe more important even than the previous one. This shows you the difference in hypotensive events between the two groups. Panel A is the deep hypotensive events. Panel B are the moderate hypotensive events. And you can see these are absolute numbers of patients, that in the NOL-guided group, just 2 patients had a deep hypotensive event for 10, well, on average, I know that there were around 10, 11, 12 minutes. And the number is much, much higher, around 11 to 12 patients in the standard clinical care. This was highly significant. If we look at the moderate hypotensive events, of course, there were more patients also in the NOL-guided group, but the difference was still quite appreciable, although not significant. The p-value was 0.055, but it gives you an indication of the difference in hypotensive events. And I'm going to focus on this a bit, and I'm going to steal some data from Professor Sessler's group. This is data from Cleveland Clinic that shows you that the occurrence of hypotensive events are quite prevalent. This is a large data set of almost 19,000 patients, and patients that have mean arterial pressures below 55 for 1 to 5 minutes occur in 25% of patients. And you can see even longer than 20 minutes occur in 4% of patients. And this is exactly what we also found. Of course, our absolute numbers are smaller. We just had 80 patients in our group, but this is exactly what we find. And I am convinced that this is a common occurrence in every clinic. I continue with his data because he shows in 2 studies that the occurrence of hypotensive events is associated with 30-day mortality, a higher prevalence of 30-day mortality, as you can see here, as well as myocardial injury in the low blood pressure areas. So if we come back to this slide, I find this the most important slide of my study, as the number of patients with hypotensive events is significantly reduced when you strictly follow your nociception index, your NOL index. So, to come to a conclusion, we observed that NOL monitoring was associated with about 30% reduction in the use of remifentanil. We saw a reduction in the number of inadequate anesthesia events with less use of vasoactive medication. I didn't show you that because of time. We saw less low heart rate events. We saw, that's what I showed you, significantly less hypotensive events, and they were all in favor of the NOL-guided group. To be more complete, we did not see any difference in propofol consumption during the procedure. We didn't steer on that. We kept it constant so that the BIS was constant. And we also did not find differences in postoperative outcome in the terms of acute postoperative pain, so in the early postoperative phase. And I relate that to the use of sufficient amounts of morphine at the end of the case. Thank you very much. I did not do this research on my own, so this is the group that was involved. Thank you very much.